Uh, the theme of my lecture today is blood component therapy. As we all know, these days the whole blood transfusion concept is going away. Doctors are most likely to give their preferences for blood component therapy, like the patients who require plasma only, who require uh, factors, blood coagulation factors, like that. Administration of blood components is often necessary in the perioperative period. Blood component therapy should be used to treat the specific indications, bearing in mind the potential complications associated with transfusion. Vigilance is absolutely critical as complications are most often due to human error. So complications are mostly due to human error. Now, pre-transfusion testing. When preparing to transfuse blood, draw a sample from the patient and send it to the blood bank. Type and screen. So, we have to determine the ABO type and rhesus factor and screen the sample for common antibodies. ABO type. As you all know, this ABO type is determined by the cell surface glycoprotein antigens present on the RBC surface. Patients may be AB or the O. Type O patients lack type A and B antigens. Rhesus factor. 85% of patients have the D antigen from rhesus group and are Rh positive. Patients who are rhesus negative are at risk of alloimmunization, that is synthesis of antibodies against foreign antigens when exposed to the D antigen. Antibody screen. Commercially available RBCs are mixed with the patient's blood in order to detect the antibodies with the potential to cause hemolysis. Type and cross. Cross-matching the blood involves mimicking the transfusion by mixing the donor's RBC with the recipient's blood. Ensures compatibility of donor and recipient blood samples. Time to obtain blood. Type and screen can usually be done within 45 minutes and the cross match within an additional 15 minutes. If antibodies are present, these steps can take much longer, especially if the antibodies are uncommon. Autologous, what is meant by autologous blood donation? If time permits, patients may donate their own blood pre-op. Patients who elect to do autologous blood donation may become anemic and require erythropoietin and iron. Autologous blood transfusion should be meticulously handled as human errors still occur with administration. Direct donor blood donation. A family member or friend may be designated by the patient to donate. This technique does not decrease the incidence of transfusion transmitted infection, as the patient may not be aware of the donor's infection status. Now we come to a very important point, that is PRBCs. What are PRBCs? These are packed red blood cells. The purpose of PRBC transfusion is to increase the oxygen carrying capacity of the blood. Purpose of PRBC transfusion is what? To increase the oxygen carrying capacity of the blood. The decision whether to transfuse PRBC is multifactorial. Patients' coexisting disease and risk of ongoing blood loss should be considered. For example, a patient with coronary artery disease will likely require transfusion at a lower threshold due to the need to maintain the myocardial oxygen delivery. PRBC transfusion parameters. There is no absolute laboratory value that necessitates the blood transfusion. Transfusion is rarely indicated for hemoglobin concentration more than 10 gram. Transfusion is usually indicated for hemoglobin less than 6 gram. Within this range of 6 to 10 gram of hemoglobin, the risk of ongoing blood loss and the patient's coexisting disease must be considered. For example, patients with coronary artery disease probably should be transfused at a higher hemoglobin than a young healthy patient. In the absence of continued blood loss, 1 unit of PRBC should increase the hemoglobin concentration by 1 gram and the hematocrit by 3%. This is very, very important. You should remember how much hematocrit is increased and how much hemoglobin is increased by transfusing 1 unit of PRBC. ABO compatibility. ABO blood type is determined by the presence or absence of A and or B antigens on the surface of the RBC. Patients who lack the either antigen are type O. Patients have circulating antibodies to RBC antigens that they lack. This you must keep in mind. For example, type O patients have circulating anti-A, anti-B, and type A patients have anti-B antibodies. Type-specific transfusion is essential. This is because ABO incompatibility leads to immediate and potentially life-threatening hemolysis. Type AB patients are universal recipients and type O donors are universal donors. So type AB patients are universal recipients and type O are universal donors. If type-specific blood is not available, type O, usually Rh negative blood may be given. FFP. FFP is fresh frozen plasma. Contains all the plasma proteins and clotting factors. Stored at -18 to -30 degrees centigrade and must be thawed prior to the administration. That means must be warmed up. Indication for FFP, rapid reversal of warfarin therapy. Correction of known coagulation factor deficiency when factor concentrates are unavailable. Antithrombin 3 deficiency in patients receiving heparin. Correction of microvascular bleeding in patients who have been transfused greater than 1 blood volume. These are for the microvascular bleeding. Correction of microvascular bleeding in patients with abnormal coagulation parameters, that is PT, prothrombin time, more than 1.5 times the normal, INR is more than 2, APTT more than 2 times normal. Recent studies in trauma patients who require massive transfusion have shown that decreased morbidity and mortality with earlier administration of AFib. The goal of FFP administration is to achieve 30% of clotting factor concentration. The starting dose is 10 to 15 ml per kg. ABO compatibility. Compatibility requirements are different than with RBC because the plasma contains anti-A and or anti-B antibodies in patients with who lack those antigens. FFP should be ABO compatible. For instance, a patient with type AB blood should receive only type AB plasma, but a patient with type O blood can receive type O, A, B or AB plasma. Platelets are usually available in 6 to 9 equivalents from pooled donors. It must be stored at room temperature, which increases the likelihood of bacterial contamination and decreases shelf life. 1 unit usually increases the patient's platelet count by 5 to 10,000 cells per cubic millimeter. So 1 unit if you give, it only increases by platelet count 5 to 10,000 cells per cubic millimeter. While 1 single donor apheresis unit increases the platelet count by 30 to 60,000 cells per cubic millimeter in the absence of platelet destruction. Indications. Platelets are rarely indicated if a patient's platelet count exceeds 1 lakh cells per cubic millimeter. Platelet transfusion should be considered in the presence of excessive microvascular bleeding with platelet counts less than 50,000 cells per cubic millimeter. May also be necessary in the presence of platelet dysfunction, that is antiplatelet therapy, uremia or post-cardiopulmonary bypass and microvascular bleeding. ABO compatibility. Although you can transfuse ABO incompatible platelets, these cells may have a shorter lifespan than ABO compatible platelets. Now we come to the cryoprecipitate, made from slowly thawing FFP, contain high levels of factor 8, von Willebrand factor and fibrinogen. Indications: treatment of microvascular bleeding in the presence of fibrinogen deficiency, which most commonly occurs due to disseminated intravascular coagulation, that is DIC, or massive transfusion. Treatment of congenital fibrinogen deficiencies or bleeding in the patients with von Willebrand disease where the factor concentrates are unable. Ideally, fibrinogen level should be obtained before administering the cryoprecipitate. Patients whose fibrinogen concentration exceeds 150 milligram per deciliter usually do not require cryoprecipitate. So you should remember this point that if it exceeds the fibrinogen concentration, if it exceeds 150 milligram per deciliter, they usually do not require the cryoprecipitate. When fibrinogen concentrations are less than 80 to 100 milligram per deciliter, cryoprecipitate is usually indicated. So, indicated in less than 80 to 100 milligram per deciliter. ABO compatibility. Because cryoprecipitate has only a small amount of plasma, ABO compatibility is not necessary. The remaining part of my lecture I will consider, I will take in my next next lecture. So I stop here for today. Thank you.